Um, I now have the pleasure of introducing a man that I feel so fortunate to have developed a friendship, a relationship, a collegial a collaboration to the extent he feels almost like a brother halfway around the world. And we have worked on many projects together over the past decade, and we are all working in a changing space, a changing technology, changing health needs, changing expectations, changing modalities of care. And through all of the decade that I have worked with Dr. Balkhair, I have been so impressed with his ability to adapt and transform and communicate and collaborate. And his openness and his spirit has been fantastic. So, Dr. Balkhair, I invite you please to take the floor and welcome you to our discussion.
My pleasure, Prof. Thank you very much. Really, I would like to thank you and thank the organizing committee for inviting me to be with you here today. Can you see me very well? Okay. And also, I would like to thank Dr. Nazi for his words and speech about some of the challenges that we are facing. And I think it's worldwide challenges. And I hope he is staying with us so that he listened to our story. If I could convince him and convince our respective audience and attendee today. My name is Ahmed Balkhair. I'm a pediatrician in profession and health informatician. And I started the journey or the introduced to the technology a long time ago, since 1982. I'm not so old, but I started so early. But I started when I started my healthcare profession. Maybe let me just start from the latest. We start the journey with Ministry of Health in building the e-health strategy. The initial strategy built in 2010, till late 2010, and since that time, usually the e-health strategy or digital health strategy started and emerged from the business strategy, how the Ministry of Health would like to provide healthcare service, and how we are looking into how all the healthcare system, the ecosystem will be integrated. And you cannot enforce everybody to use the same system, but you can unify the standards. And from there, you can start the interoperability or information exchange or orchestration of healthcare service. So from here, you can start. We would like, for example, the ministry thinking to have a continuum of care, starting from primary health care to secondary care to tertiary care, quaternary care, to have it in a continuum of care. So having the file of the patient moving at that space of work. But how to think of that when you are thinking of different healthcare providers, like Minister of Health providing 60% of healthcare service, but 20% is provided by other governmental sectors like universities, military hospitals, National Guard hospitals, Aramco, King Faisal, and so on. And 20% or more, a little bit, provided by the private sectors. And the private sector hospital is, although it's 20%, but it's also it's a very respectable amount of service. How are we going to have a continuum of care across different sectors where you cannot unify the systems? And further challenges, I will start now. That was in 2010, where we work in the two levels. What we would like to do at the national levels, where we would like to unify standards, unify coding to lay the ground for the interoperability across different healthcare sectors, and at the same time work in Ministry of Health to have the systems integrated, the primary health care, secondary care, tertiary care, per each zone in the kingdom. Now, I would like to tell you also what happened when we are in Ministry of Health transformational changes. Now, the business in Ministry of Health is changing. Ministry of Health used to be a healthcare provider and also healthcare regulator. But in the vision of 2030, Ministry of Health going to be only a healthcare regulator, and they will push the healthcare provision to clusters. Clusters, it's more or less similar to the regions now, but going to have 20 clusters. Each cluster will be an accountable healthcare care organization, which have a total independency. They will be self-managing an area of 2 million almost of population, plus minus, with around maybe 10, 15 hospitals, around 100 plus primary healthcare centers. Now, this is one of the changes that's going to happen, which is considered changing how we are going to cluster the surface. So we're going to have 5 zones. Each zone can have a group of clusters. Changing this, it will change the whole structure, because this accountable healthcare organization should be able to calculate or measure their cost versus their outcome. We are not looking into only improving the quality or improving only the performance. We want to reach a value-based healthcare service. So we want the quality as well as the safety, as well as the outcome. The other changes among these 7 dimensions in the governance is changed with the clusters. The corporatization, as I mentioned, is changing. How we are going to fund this healthcare service? So these clusters are going to be unaccountable, and they're going to be paid based on their outcome. The other thing is now the service in healthcare is changing. We have the new model of care. New model of care is tackling the patient journey of life since birth, and antenatal care, during the emergency care, the planned care, emergency care, until the chronic disease surface and end of life. So these changes the model of care, how we would like to activate the patient, so we can empower the patient, and let the patient easily access to the service, as well as deliver the service directly to the patient. So that because of the introduction of many of the emerging technology that came through. In 2010, we do have something, we call it mobile health and telehealth services, but we didn't have this big spectrum of emerging technologies that really introduce and change the way we are providing healthcare service. And even the current model of care that we are designing now is changing. It's not, we think of telemedicine or telehealth, then mobile health. Now it's a virtual space that we are dealing with. We are thinking in the near future, we're going to treat a lot of patients at home with IoT devices, where we can monitor them remotely, visit them at home, giving them their medication. So things are changing. The patients themselves are changing. With social media, with access to information that they are having now, they have a lot of requirements. They request a lot of things, and sometimes they challenge their physicians on their treatment. Social media is changing, so a lot of dimensions, factors affecting the current strategy that we built in 2016, 17. And as we go, we do a refreshment now every 2 years with the new things that are coming. The cloud computing, artificial intelligence is also changing many of the services we are providing. Now, part of the changes, if you give an idea since 2010 and 16, 17, is that we are moving everything now to the cloud. You know, Google and this big organization, they couldn't reach to this size without having things in the cloud, and without this reducing their operational cost, reducing their security cost overall, I mean, as well as they are more integrated because there are lesser application used, and they are all in the same environment, can be integrated much easier. We move into an OpEx, because this accountable health organization need to calculate their operational costs in each and everything, even on the system that they are hosting. By the way, in some of the facilities in the States, it reached to 10% of their overall cost of the facility, of the hospital, the cost of the HIS system. And how if I have a cluster like Al Qasim now, for example, and Medina, where we move all their systems to the cloud. Now 17 hospitals in Medina are running all in the cloud. And similarly in Qasim, around 16 hospitals are running totally in the cloud. In the north, almost we are reaching now 28 hospitals in the north and south are running on the cloud. And so we are moving things to the cloud that will reduce it will move into an OpEx cost. And we can share a lot of horizontal services. In 2010, we are thinking to be centralized whenever it's possible and decentralized whenever it's necessarily. Now, the necessarily things are becoming more and more to the lesser extent, and we are having more things that can be centralized, even the imaging. By the way, we are in the current project we are awarding nowadays 280 hospitals of Ministry of Health. Their PAC systems, almost in all of them, are going to be hosted in multiple data centers, but I mean in a central manner. Even the cardiac PACs, although it's too huge images, very heavy to be hosted centrally, we're going to have for all these hospitals, and including the regular PACs, I mean, a cache in the hospital, but it will be the cloud. So moving also to the clouds, some of the services to be shared in OpEx manner, like we have a laboratory solution across the kingdom, is not awarded yet, and this is supposed to be also for 15 almost regional labs of the Ministry of Health, going to be also centrally hosted. Standard and policy is one of the things that we work and with Dr. Prof. Elliot since 2013 until 15, it's finished for the main important things that we're looking for, which is interoperability standards as well as policy. We will see it in the coming slides. And the telehealth service, how we have a unified telehealth network where all different healthcare providers can communicate with each other without difficulties. So I can, in one hospital, communicate with a clinic in another hospital, belong to a different sector. So this way we can reuse, similar to the phone where we are calling somebody else somewhere else. If we reach to that point, it's going to be great. So these are the main portfolios that we have. The standard policy is something of great importance, as you know, and also the information exchange, which is here the last. The things in the middle, including information security, digital infrastructure, citizen health services, clinical solutions. This is how to empower the patient directly. Clinical solutions within the facilities, business solutions, which is the background support, like as mentioned by Dr. Nazi, how to do tracking for assets, as well as tracking for all types of resources that we are utilizing within our facilities, and even include tracking and building like sort of what's called it cost center for each of these facilities. If you have 17 facilities belong to one cluster, they want to evaluate the breakdown of the cost for each of these facilities, so that this way they can calculate even their prices if they are going to sell the service to others. By the way, some of the other dimensions that I mentioned in the transformation is that Ministry of Health with their clusters, they would like to have the capability of selling services, the extra capacity they have, and buying services from the private sector wherever it is needed. So designing solutions that have that capability, it requires special architecture. So as I mentioned, these are the drivers: corporatization, governance, private sector participation, which is buying and selling, the FAB, which is the body that's going to pay the governmental, these clusters of Ministry of Health, going to pay them based on their performance, how we transform the workforce, and how we can really consider them as a cost as well as profit centers for each of these resources. The physicians are going to be maybe working in multiple facilities at the same time, how we can utilize their extra time, and the model of care, as I mentioned. Now, this is how it looks like, the main programs and projects. Some of it are with dark dots. It's not clear in here, but just I will give an examples of it. Are considered national projects, the projects that are going to run at a horizontal level, integrating all sectors. The one in a pink color, this one, or orange color, the light orange color, these are the solutions that we need, or projects for a solution going to be implemented within the facilities, like the health information systems, the primary healthcare solutions. So some of the solutions like the security should be implemented in all the 3 levels. What is the level in the middle? Sorry, is the what's called the shared services. So we have clusters in the kingdom, in the Ministry of Health. Some of the services are going to be running in a horizontal level across these clusters, like the laboratory solutions, going to be implemented in the 15 regional labs. The other example is the PAC solutions going to be running in a horizontal manner, although it's virtually divided per cluster. So the costing will be per transaction. So in this way, it's easy to calculate and easy to collaborate, exchange, doing sort of a cross scheduling, cross reporting. They will be able to collaborate, whether the clusters with each other or even the clusters with the private sector. They can sell and buy services. So the example of the central, the national components is the unifying the standards. This is something at the National Health Information Center. They are responsible to create the standards, to maintain it continuously, to build the registries that we will mention after a while, to build the National Health Observatory, which is the horizontal, we call it business intelligence, but at the national level. The enterprise one, as I mentioned, example of the lab, and the hospital base is the one, the cluster base, like the HIS systems. And this is in the 4 dimensions, where there is the clinical programs, the solutions, and here for the infrastructure, and the personal health information, like the unified health record and so on. So in the business side, we have the challenges, is the access to care, disease burden. We have a lot of aging now, and the chronic disease is becoming a challenge. The quality and safety, how to maintain it, and so having solutions from our side to maintain operating using the evidence-based best practice, as well as having sort of a clinical decision support systems. Safety, this is a clinical decision support system to avoid any mistakes and so on. The workforce, how we work in even learning management system and so on. Some of the systems are at the national level, and some of it how we would like to execute it at the horizontal, at the vertical level within the clusters. The cost, how also we'd like to maintain the cost. See, these are the main dimensions. I'll try to speed up because several dimensions requested to try to go over it today, and it requires actually a longer time. When you look at the ecosystem, it have many dimensions, many players. So if you look at MOH, as well as which have these 20 clusters surrounded, how the corporate's going to be, the corporatization, which is in each going to manage this, the holding company who is managing these clusters, NIPCO, which is supplier currently for the medications, and if you would like to orchestrate the dispensation of the medication through private sector, through the regular pharmacies, as what we are doing now in the e-prescription project. Now, more than 2 million prescriptions only over the last year. And doing that, how we orchestrate with NIPCO to do that and to do the payment through in the future through the FAB, the vendors who are providing the different solutions, and how we look into this service. So the player, this ecosystem is too many. And usually when a digital transformation, it's starting initially with the digitalization, as mentioned by Dr. Nazir, is having the hospitals having an HIS. And to have that HIS in a way utilizing a standard to have electric health record within the facility. And then and how to empower gradually the facility to be more smarter. In the digital transformation, we would like to integrate connecting these systems. And when we have the whole different modules across the enterprise running, like as I mentioned, the central packs, central lab solution, whether a central blood bank, central pharmaceutical like the e-prescription, you can re-innovate and reimagine. So some of the solutions for the agility, we started from the end. So we start to provide the booking system. So Ministry of Health start with a booking system, which is running here as an enterprise. So these are the solutions that are within the Ministry of Health. It's running as an enterprise or as a cluster. These are the clusters or enterprise solutions. So even HIS of Ministry of Health considered at the cluster level. So the booking system, we have now more than, I think more than 13 million subscribers. And we did only over the last 2 years, more than 60 million bookings in 2,240 primary healthcare centers in the kingdom. And this is in the cloud. And similarly, we have the central lab solution and imaging solution. It's going to be the same manner. And imagine these all enterprises, it gives us a capability now we are moving into having a unified app, which is called Sihhati app. It's starting now. You can download it. It gives you now a minimal functionality. By time, it's going to be integrated with many things, integrated with the central booking system. It's currently in there. And you can see whatever sick leaves that you have done. By the way, sick leave, it's at the national level. It's because connecting with all healthcare services, but you're going to find whatever sick leave is issued for you. And you're going to see if home healthcare service will be the interaction through it. Any vital signs, activities I am doing, it will be pulled from healthcare. So these are the solutions going to be either at the enterprise level or within the facilities. This is the other sectors, they're going to have their own systems. And these are the national solutions that Ministry of Health is building, but it's going to be running across at the national level, like the blood bank solutions, like toxicology solutions, forensic solutions, and e-sick leave, as I mentioned. All these are running at the national level. Now, what's called Nafis, which is the unified health record, going to be a longitudinal one, which is collecting from the different HIS systems based on different use cases, the most important, valuable data that we are looking for. From here, after a few slides, we're going to go into the details of Nafis. How does it work? How we build it? And what are the components of that Nafis? So this is in a very quick manner. So in 2010, we started initially with a minor things. Everything is a standalone, limited functionality, no interoperability. A lot of things are lacking. In 2015, we reached into a point that we started to have public health solutions. We started to have system focus, some of it like the public health lab operation system, some HIS here and there, but it's nothing, not all of integrated. And also the HSN, which is the public health solutions, is there. In 2017, when we start to rebuild everything, so we start to move everything to the cloud. That help us to reduce the number of solutions, reduce the operation, because we have a big challenge, and you know that in the number of your resources in the IT as well as in health informatics and information management. Also in 2015, we already built with the IHE. We start 2013 until 2015. We finished the interoperability use cases that we are looking here for, which were around 15 use cases and the 9 policies. So it was ready by this time. Supposed to award here the information exchange engine, but what happened with the transformation here, with the business transformation of Ministry of Health, when we start to think of how to be more optimized and for this engine to be sustainable. You know, the cost of building information exchange engine is not only in the building of the engine, but the operational cost of that engine is the biggest challenge, because it's by time they're going to aggregate huge amount of data. By time, more and more use cases is going to come, and you need that to be sustainable. And to make it sustainable, at least you need to be similar to the OPEX manner, the one who will pay the beneficiaries. Who will benefit from having a unified record, unified health record? First is the patient themselves, and the second is the payers. So if the patient information is aggregated, the payer will pay less in the coming visits, whether he go to a different hospital or even a different sector or a facility. He's gonna see the previous investigations and medications and history, and that's why we analyze how we're gonna merge, how we're gonna solve that, and that was a direction from His Excellency the Minister, how to make this unified health record so optimum and sustainable. And that analysis reached into a point how to merge the clinical engine as well as the financial engine. The current financial engine available is the payment from the insurance companies to the private sector. And with the transformation, we have these clusters that are going to be paid also by the FAB, which is the governmental arm that's going to pay these clusters. So we have 2 payers that are going to benefit from this unified health record. So we work to merge these 2 things, and we're gonna see it after a while. Okay, so these are the vision is we are working with the in the new model of care, how to do case coordination, how the healthcare providers, although they are maybe sometimes in a different clusters or in different locations, they can communicate with their patient. how how we can empower the patient to access to the care and to be able to deliver the care to them anywhere. How to help the innovators, the developers, with a working space, having an engine that have all the registries as well as the clinical data, so we can build more and more services, ideas, reimagine actually the situation. And in this way, that's going to help us actually to speed up transforming. Maybe we'll be innovator in creating new model of care in the futures by having this ecosystem integrated. Also, the researchers will benefit a lot, and having this data aggregated going to help us with artificial intelligence in the coming futures. It's going to have a bigger and bigger role, and we might be a producer to many of the algorithms. Now, by the way, if you can, we have a project that we have 9 cardiac centers, all utilizing single PACS, cardiac PACS solutions, and having that amount of cardiac images going to help us actually to go into this era of building algorithms that can predict, classify, or help us really to predict some cardiac problems for our patients. These are the levels where we would like initially quickly to let the patient improve their access to care, so they will feel really the change and the improvement in healthcare service as quick as possible. That's why we introduced the app Sihha and the Maw'id and many things that really let the patient feel empowered. And then how to improve the quality of care with the solution that we are introducing. We are working with our colleague to improve many things. Sometimes you start things with agility, and then afterward you can improve it with an additional functionality and features. The value base, which I mentioned previously, this is what we are looking for with building the unified health record and merging Sihhi, which is Saudi Health Exchange Engine, and CHIP, which is the Saudi Health Insurance Bus. And with what FAB is looking for currently, to have a project in the middle, we call it Nafis. And at the end, this is with the precision medicine, how we can predict, how we can communicate with the patient. This is what's called the National Health Observatory. So aggregating the clinical data from Nafis, as well as the administrative data with the current integration that we are doing now, which is speed up, by the way, very quickly during COVID, because we need really to have an instant or quick visibility to the status of the resources, whether it's a medication, human resources, beds, and even consumables. We need that actually to monitor the situation in the command center, and it pushes us very quickly. Currently, we have more than 85 hospitals connected in the National Health Observatory, and it's giving us a lot of data. Now we reach into Nafis. Nafis is as I mentioned, is a platform where we are trying to interconnect all healthcare systems, whether the national one, like the public health solutions, vaccinations, and these are in a centrally hosted, the lab solutions, PACS, and as well as the vertical solutions, which are implemented within our facilities in a distributed manner. How we can connect them all together, in addition to the transactions related to the financial purposes, like requesting pre-authorization for a service in a private sector, and then approval for the service after it's finished, claiming their payment, and so on. Nafis merge both projects together. In the interoperability, as you know, if you are connecting the hospitals in many situations, it will be so many number of integrations going to be required. But if we do it in a hub, using in a loosely coupled manner with the unified standards like the IHE that we are using, plus in certain areas the FHIR standards, it's going to be lesser in the complexity of integration. Each of these facilities, based on the service they are providing, it will be affected how many use cases they're going to use. The hospitals, for example, have all the services, so they will use all the 15 use cases. But if you go to the laboratory centers or a pharmacy, they're going to use maybe 4 use cases, only the one which is identifying the facilities, that identify the patients, as well as the medications, whether dispensation or ordering. So when we look into the different countries, whatever solutions they are, it's few, not many countries. In the state, I think there are several states. Each of these states, they have sometimes some of the advanced states, some solutions that they integrate together. Sometimes they have an organizations that do that. But at the national level, we are the 5 almost known countries that are working in that direction. We speak about it before. So the benefits of Nafis, it will improve the efficiency. So it will be, we're going to have a real availability of the longitudinal patient data. It's not all the data, but it do have all the lab results, images, reports, and whatever reports, whether it's, for example, surgical notes, referrals, antenatal care, discharge summaries. So it's covering use cases. We select this based on a workshops. You would like to ask the physician, when you have a patient in your clinic, what data would you like to have? Also, it will help us to improve better accessibility. So this is standardization of the data. If you have an HIS in a hospital, you did the lab results. These lab results will be aggregated in the unified health record. And if the patient go to another hospital, just create his new file. He go to the physician clinic. When he just check his lab results, he will be able to access all the lab results that are uploaded in the unified health record instantly, as if this patient known to have a previous file. Having this capability, it require all these preparation that I mentioned regarding building the standards and policies that we will reach after a while. So also it will help to improve the healthcare quality and patient safety. So to improve the healthcare in KSA using Nafis, it will help us building this engine, merging both together, the clinical and financial, to have a sustainable model. We'll be able to access everything. So we have better analysis really of the value base, of the outcome, of the situation of the healthcare, public health, and so on. Improve security and privacy. We have unified access, and we have a policy that secure these components. Operational efficiency, improve information access, better decision making, better patient relationship, improve patient safety, better provider, even collaboration, as we are using the same shareable unified health record, improve care outcome, and improve communication. We look into the patient journey as a whole. So we do merging these two components of the two engines. So the patient, if he go to a hospital, whether he will request pre-authorization, we look into all the journey, whether he is going to private or governmental sector, and how it looks like, and try to secure that all the transactions are available, whether the happy scenarios or the sub scenarios that are expected. Also, it will help us really to transform really the healthcare as a whole. As I mentioned, many things we will be able to do many additional advanced things in the coming years when this engine platform is on the ground and the facilities start to be integrated. Starting from the transparency, understanding all the healthcare service, having this unified health record, interconnecting all providers, healthcare providers, as well as the payers, and really achieving what's called value-based healthcare service. And we will be able to coordinate between facilities. Whatever any business model coming, we can also do it. We can empower the patient. He's going to be able to access his file. He's going to be able to prevent anybody from accessing his file. He can monitor which facilities or which physician access his file. So it have two components. I mentioned CHIP, which is Saudi Health Insurance Pass, which is used to be only the platform that are concerning with the insurance. So interconnecting between the insurance companies as well as the private sector, which is improved the council, which is the for the health insurance, Council of Corporative Health Insurance, of their operation, and regulate, control, and monitor what the insurance companies are doing, and they can monitor. They can have better visibility to improve that business, and the way they were charging the insurance companies is per transaction. These are the main business services or the use cases that they have. So the eligibility management, claim management, fraud management, marketing relation, the insurance management service in the CCHI, as well as the payment management. And if you look into it, you're going to find some components that are similar to what are available in Sahih. We will see it after a while. So the outcome will be improving the quality of insurance, protecting the right of the insurance stakeholders, as well as the right of the patient and healthcare providers, and reduce the fraud. So if we move to Sahih, which is Saudi e-health exchange engine, which is the engine for the clinical data. Now we are not mentioning anymore these names, not Sahih nor Chip. It's become one engine. We call it Nafis. So these are the components in here. It have these use cases, which managing the lab test orders, the lab results, managing the summaries, different summaries, managing terminology, medications, whether ordering or dispensation, managing the reporting of the images, and allergies. So many components among the clinical data that we are looking to have. And with this project, we are supposed to have a patient portal as well as provider portal. The provider portal where he can visualize this EHR, electronic health record, that's aggregated, the longitudinal electronic health record, as well as making some orders like ordering medication. This is specifically for the solo physician. But for the physicians working within the facilities, they will not need to go to the EHR. Within their facilities, they can make their orders, and with the messaging that standards that we are building within this standards, the system within that facility will communicate directly through the engine. This is similar to the banks. You know, you can draw money from any ATM machine, even if you are in different banks. Automatically, you're gonna receive your SMS from your bank. Things are moving. It's a messaging. This is a loosely coupled, systems using unified standards. And similarly, the physician, he can use either his HIS system within his facility, or if he's a solo physician, he can use the portal that we are going to create. These are the fixed components that need to be within any engine like this. And this is one of among the shared components. So the patient registry, the patient should have a unified health record, single registration for the patient across the kingdom with a health ID. And also the provider registry. So we need to have a unique registration for the professionals, the healthcare providers, and managing also the location registry, the terminology. We need to use the same terminology across all healthcare system, and this way will give us ability to evaluate the quality. So these are the 15 use cases that we targeted, that I read before, and these are the policies that are required to run such an engine. So the authentication, consent access control, security policy, identity management policy, audit, purpose of use of accessing to the service from the professionals, also policy, breach notification policy, subject of care policy, and secondary use of the data policy. So these are the dimensions that we build as a standards, and that will help us to build up this engine, which will help us to digitize unified health record, improve efficiency, quality of provided healthcare service, reduce the cost, and establish platform to improve healthcare decision system. So in this way, we're going to have this electronic health record that's to have the data available for the right people, right time, and at the right place to provide healthcare service. This is how the conceptual architecture will look like. These are the components that are common. If you see the key in here, where is it? In here, that's it. Anyway, so these are the common components that are going to be used by two engines. This is the clinical components, and this is the financial components, which is for the insurance. So everything in green is the common, and all the one who is going to access the system, like the providers, the patients, the insurance companies, e-claiming, the call centers who do the support, the payment gateway. We have sort of eligibility and so on. So there's an additional details of how is the conceptual architecture of Nafis look like. This is to a little bit also more in-depth technical. What are the master management and the applications and so on. So it's here financial, clinical, shared. Okay. Okay, this is also the way how the access is similar to the previous one. So the unified health record benefit a lot to our healthcare systems, and we're gonna see how it's gonna have this 360 degree of transparency. I think the interconnecting of all healthcare and insurance systems, patient empowerment will be easy. So gonna access to see all his data, and he will be able to block, allow, and do anything with his unified health record. Coordinate care. We're gonna have ability to do an orchestration. You can make an order of medication in a hospital, and you can dispense it to any pharmacy based on the eligibility of the payment. If you have an insurance, it's gonna be under the insurance. If he's from Ministry of Health, it's gonna be under Ministry of Health through NIPCO. If he is solo, then he gonna or a patient alone, then he gonna pay in cash. So this will orchestrate between the different players. It will support really transforming into a value-based healthcare service, and it will support also the operation and clinical performance improvement. I will here I finish the area of related to the صحي and unified health record. I will go through the COVID. I don't know how much time I have, but I'll try to do it as quick as I can. Okay, in G20, I am among the team who work in the Ministry of Health. We have different proposals. At the digital health, we have two main proposals initially, but it changed by time. Initially, we were thinking of how the G20 countries were gonna collaborate together. Where are the most important things that they can collaborate at this time? You know, similar to the globalization now, where you can buy from home from anywhere worldwide, and which require a lot of governance and management for taxes and many things to be sure that things go fine. Now, the telehealth is one of the challenges. It's a good from one side that provide healthcare service, so I can request any physician worldwide to give me his consultation. But who will keep my rights? Who will assure that this physician have the licensing, if he's approved to give this service or not? Who will manage that? In the kingdom here, we build up what's called the telehealth policy, which is whoever, any organization would like to provide telemedicine or telehealth services, they need to have certain rules, they need to have certain certificates, approvals to be able to provide healthcare service. How are we going to do this when we are running across the borders? So it was one of the points that we raised to be discussed through G20. The other point is something futuristic, which is we have a lot of data that we are aggregating in each country. And this data is very valuable and it's worth a lot. But it will not worth that much if it's not standardized in a way that the humanity can benefit from it by aggregating data and then building algorithms that are going to help us in the future to have a better artificial intelligence. So how we can collaborate in running certain standards or in building data models, how are we going to have our systems that are ready with the data elements that's proven to be enough based on researches, based on a previous modules that are built somewhere else that have a good algorithm with a good percentage of accuracy. So how are we going to share this type of knowledge so that everybody, when we are building new systems, we will be ready for that? So that was the two items that we proposed. But in the beginning of this year, when the kingdom started to have the chair of the G20, something else emerged, which is the COVID. So the subject by everybody changed into in a state of emergency preparedness for any new pandemics happening. So it's changing to that subject. And so we worked into collecting the country's experience in the public and private sector from the also in international organizations. We collect data about what's what they have done, what are the priorities they have done, what things that they implement, solutions that they have done. We try also to communicate, and a lot of effort going and coming have been done. we contributed in that discussion around 22 countries, and including the GDHP, which is Global Digital Health Partnership Summit, Global Fund, ITU, OECD, and the UNICEF, also WHO for sure. And then there are task force also from the Digital Health Task Force, and some subject matter experts from around 39 of them from 17 countries. They work to review these things, and we have several meetings, around 7 meetings since September 1st, and we issue a document. You can find it in this URL, which is digitalhealthtaskforce.org, which is till 2 days ago. It downloaded 1,300 times from 70 countries, and that have the recommendations for how the pandemic preparedness on the coming, the approach to implement the pandemic management in the future. So it's even the wording is shifted into a pandemic management like preparedness, and based on that we have around 11 recommendations. 4 of them is already assigned. WHO will do 3 of them, and another one I think going to be by WHO in addition to the one of the organizations. I think the ITU, and an additional one will be done by the Kingdom and before the end of this year, and a remaining 7 we are looking for how this is going to be fulfilled during the coming year. Now, how we did during COVID management during this year. Now, imagine when this new disease coming, starting to spread worldwide, and which we don't have, nobody have much of knowledge about it. The informations are coming slowly, so you need to understand. So initial effort is how to aggregate, and all, by the way, healthcare sectors and non-healthcare sectors work together in boards and levels of management, actually, with the highest management in Ministry of Health and these different organizations. They work together to plan in all things. Initially, how to prevent this disease from reaching to the kingdom, how to prevent this from reaching to the kingdom. And one of the initial solutions was to be used, which is tatamman. So anybody arrived to the kingdom, how to ban him for 14 days at home. For the people, we need to also provide them with their information to avoid any incorrect news, how to give them a daily information about situation. We have what's called COVID map, which is showing the diseases, how does it spread in the kingdom one by one every day. We start to have a self-assessment for the patient, which we made it in Maw'id application, as well as in Tatamman and in Sahha app. So the booking over this year, only during even this attack, we have I think near 30 million bookings only over this year. And then with this booking, we overall we have more than 13 million subscribers. We in the Sahhati app, which is the app that I mentioned before, that to aggregate all the services, we do have a lot of management related to the sick leaves, e-prescriptions, as well as the booking for the COVID screening. So we have more than 4.5 million bookings for screening for COVID done through Sahhati app. And as well as this is the Tatamman app, the initial app that we started with, also to know if either you are infected, if you are also in a contact with the patient, how much you need to be isolated. And by the way, also we add for geofencing an IoT device where it can be used for the infected patient. This is with a collaboration with Sadaya. Also, we have with Sadaya something called Tawakkalna. This product during the banding of the people at home, and how it will help us a lot for those who are really infected or banded, or sometimes if you are going to a hospital for a booking for appointments, or if you would like to go out for an emergency, how we really this is developed by Sadaya, how they could orchestrate the whole nation movement. By the way, this app, one of the apps that have around 18, I think, I didn't remember, I think 18 million subscribers that occur only within, I think, a matter of 2 months. And because it really, maybe all of us here in Saudi, they know about, because it managed this movement. Even if you are a physician working, so the timing that you will go and come back, this is will help you automatically to allow you to move or not. The buyout solution is using the technology of Google and app that's generated during this pandemic. It's built by Sadaya. So you see all the different different sectors, whether health or not, we are working together in this. And this is, by the way, securing the privacy, and it doesn't know anything about your identity, but it just measure if you are coming in nearby somebody. It count all this nearby, the time, the distance, as well as the how close you were with that person, and then whenever any of you turn to be positive, it will count how many days, and then will send a notification to the center that the one who have this registration code or whatever. So it will send you a pop-up notification that you were in nearby to somebody who turned to be positive. But the system will not get your identity, will not know you, but this will help you greatly to be to identify these unknown things. This is the virtual clinic. By the way, it started prior to COVID, and it's one of the things that we're trying to do in the kingdom. I think it's more than a year ago, or less than a year ago, sorry, to use this virtual clinic where the patient can visit the physician. It's similar to Siha app. Siha app is a very well-known app. It's have over this year we have near to 2 million consultations on this app, where the patients can communicate with the physician instantly for a teletriaging, with a text, video, voice. And now this year during COVID and last Ramadan, we launched the chatbot using the Babylon. After we worked to translate it to Arabic, it took a long time to work to Arabize it, and then so the patient can do chat with this app, and then at the end of the chat, whether he would like to speak with a physician, he can continue and speak with a real physician, or he can book an appointment in the primary health care, or if the app direct him to go to emergency, do teletriaging, and sometimes give some recommendations, and most of the times give recommendations. So this is Siha. This is Wasfati, which is the e-prescription. Now, over the last year, we have, by the way, 2,240 primary healthcare centers. Now, almost 1,200 primary healthcare centers, they are not dispensing the medication from that primary healthcare centers. These prescriptions will come to your mobile, and you can go to any of the nearby pharmacies. There are listed pharmacies, and then you can dispense your medication, which have a lot of acceptance and patient satisfaction, where they have a lot of variety. The shortage of medication, it goes to the minimum. Even the operational cost and the handling cost of the medication is reduced. This is the e-sick leave, as I mentioned before, and there's millions of sick leaves now. Most of even private sectors, all of them, their sick leaves should go through this system. And by the way, it helps us a lot to understand the nature of these sick leaves. The Ministry of Civil Services, they are benefiting a lot from understanding the behaviors and many other things. Okay, so this is part of the public awareness that we did during the COVID, healthcare workers awarenesses. And this is how the AI is benefit. We benefit, by the way, during COVID from the AI in many dimensions. One of them is the analysis, the initial data that we receive, and the interventions of the Ministry of Health and the board of this COVID decisions. We see how these interactions affecting the number of cases. His Excellency mentioned one of the times that we are expecting the numbers to go either this number or this number, and it goes exactly as that, based on these analysis that have been done. And we managed to go with the curve down to make it flat, to reduce the number of cases. And the command center that we see the first slide, We are monitoring even each region, the number of beds, how is the situation, the resources. So whenever these goes into certain levels, at each level, interventions are decided. So at certain levels, we move to private hospital. At certain levels, we have to move patients from this city to another cities, so that we keep availability of the beds always. Also, the AI in other areas, it's used for medication development. It's used and also we use it by the way, we are trying to utilize some of the solutions that NHS developed. They use it for classification of the cases of the risks. So based on the coding, if the patient, if you go online and then you put all the list of problems that you have, the system automatically will tell you which risk level you are, either low risk, intermediate risk, high, and very high. And that was very useful. Actually, we are also working to use the IoT to be able to monitor patients at home. But still, we are under experiencing this because most of the IoT devices, the oxygen saturation is just newly introduced. Two researchers who work with them, they are introducing it newly, and that will be very useful to monitor the patient at home. You know that 50%, we are admitting 20% of the cases. And among these 20%, half of them, which is 10%, they require really to go to ICU or to require a real hospital services. And even those half that require this service, they require it on day 8 or after 8, 9, sometimes 7. So if we could keep this patient at home by remote monitoring, it will reduce the cost massively. So this one is some of the things that we are working at, and using the AI to be able to classify the patients in a very smart way will be very useful to reduce also this number. So as you see, digital health is going toward all these things. So whatever challenges coming, we try to find in any of the emerging technology a resolution idea to work around it and design a solution for it. I hope I try to cover as much as I can in the solutions, and I don't know if I do exceed the time. I'm sorry for that if I did.
Thank you, my friend, Dr. Balkhair. I have worked with you for a decade, and every year you inspire me. Your work is inspirational. The map you showed of the world, I can tell you that Health InfoWay in Canada and the programs in Australia are nowhere near what you have achieved and what you have as your goals. Here in the US, it'll be another 10 years, maybe 20 years before we hit that. These kinds of goals, other than in small locations, and sometimes I think maybe I should move to the Middle East in order to get modern medicine. So thank you from the bottom of my heart, and your team and your community.